Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of summary of standard medical textbooks. That is nothing but standard medical notes. Today let us discuss the topic of cardiac arrhythmias in general. So moving before to the main topic, first we will learn about the basics of cardiac action potential. Okay, so as we know, this is the heart, this is SA node, this is AV node, this is bundle of His, this is right bundle branch, this is left bundle branch. Left has left anterior and left posterior. These are the Purkinje fibers. Okay, Purkinje fibers. So normally SA node is the pacemaker of heart, pacemaker, and AV node has a high resistance. It has a high resistance. So next is the bundle of His. Bundle of His, from which originates the right bundle branch and the left bundle branch, anterior and posterior, and Purkinje fibers. So this is nothing but the wiring of the heart through which the electrical signals pass. Again here there are three connections which the names of which I don't remember. Okay, so SA node normally it will generate the impulses and it will send to the different cells, to the left atrium, to the right atrium, and then to the AV node. From the AV node to the bundle of His, from the bundle of His to the bundle branches, and then the Purkinje fibers, through the Purkinje fibers to the left and right ventricles. So that causes contraction of the atrium and ventricle in a coordinated manner. So first the atrium will contract, then the ventricles will contract. That's about the wiring of the heart. So let us learn about the pacemaker potential and cardiac action potential, because both of them are different. So let us first learn about the pacemaker potential. This is important to know. Okay, pacemaker potential. Remember, normally every site of the heart, for example, SA node has its own rate of generation of impulses. AV node also has its own rate of generation of impulses. Bundle of His also has its own rate of generation of impulses. Ventricles also have their own rate of generation impulses. But as you come downwards from the SA node to the ventricles, the rate of generation of impulses will decrease. For example, SA node normally has 80 approximately average, if we take 80 rates per minute. AV node will have lesser than that, and bundle of His lesser than that. Ventricles will have lesser than this. So here SA node becomes the pacemaker because it has the highest generation of impulses per minute. So it will take over the control and it will become the pacemaker. It will become the boss who will give signals to the other cells of the heart. Okay, it will send the signals. This is the norm, and it will maintain the harmony between the atrium and ventricle, so that they will contract in a coordinated and synchronized manner. Okay, so in arrhythmias we will learn that when this is lost, that's how the arrhythmias occur. No, so when this pattern is lost, arrhythmias will occur. So first of all, we'll learn the pacemaker potential. Okay, SA node potential. So normally there are something called as funny currents. If this is there is a basement membrane potential, as we all know, that is maintained mainly by the sodium potassium ATPase pump. Outside will be positive and inside will be negative. That is the normal membrane potential which every cell has in our body. But when it is depolarized, outside will become negative and inside will become positive. That will generate a potential, a voltage it will generate, a current it will generate. Okay, and that current will cause electrical and EC coupling, electrical contraction coupling. Okay, current will cause contraction of the muscles similar to the skeletal muscles, but the action potential is different here. So remember, membrane potential is nothing but the potential a cell which has at the baseline without any impulse. Okay, and action potential is that amount of potential which generates action. Okay, that's why it is known as action potential. And pacemaker potential is the electrical activity which goes on in the pacemaker, nothing but the normally is a node of the heart. So it has a special property that it itself depolarizes. That is a special characteristic feature of pacemaker. It itself depolarizes by something called as funny currents, funny sodium channels, funny sodium invert currents. Sodium will get inside when the asynode reaches to the basement membrane. These funny currents will open and sodium will get inside, and the membrane potential will rise to this threshold. At this threshold, what will happen is, at this threshold, L-type calcium channels will open. Next, this is sodium channels, funny sodium current channels. Okay, L-type calcium channels will open inside. Okay, inside. So further depolarizing the SN node. So that will generate a spike like this. Remember, these L-type calcium channels are slow channels. Not like the sodium channels or potassium channels. Sodium channels are fast channels. L-type calcium channels are slow channels. So pacemakers usually use the slow channels. Okay, so SA here the calcium channels will open, and at this point this will close. Why this will close and the potassium channels will open? Potassium channels will open outside, to the outside, so that potassium will move outside of the cell. So the cell will repolarize now like this immediately, and it will come to the basement membrane. So reaching to the basement membrane is the potential, is the impulse to the, again, to the funny sodium channels. So again those channels will open and sodium will move inside. Again here will calcium channels open, and this will cycle, they will continue. So that's about the pacemaker potential. Okay, it is different from the cardiac action potential. Now let us learn about the cardiac action potential. So normally it is minus 90 millivolts. So when the SA node sends impulses, so this is known as this stage is known as stage 4. Stage 4, fourth stage. Okay, so when the impulse reaches here at this point, the fast sodium channels will open. Sodium channels will open. So there will be a spike like this, straight spike, because of this fast sodium channels. Okay, at this point what will happen, the sodium channels will close and potassium channels will open inside, open outside, sorry. So potassium will move outwards, so it will cause repolarization for some time, like this. This is known as, so this stage is known as 0 stage, and this potassium channel stage is known as first stage. And at this point what will happen is, the L-type calcium channels will open inside. That means the calcium will move inwards. So there is a what do you call, fight between potassium channels and calcium channels. That fight, potassium will try to repolarize the cell, and calcium will try to depolarize the cell. So that's why there will be a balance created between those two channels, and there will be, for some time, there will be, the action potential will become plateau. This is known as plateau phase or phase 2. phase 2. This is phase 2, also known as plateau phase. So here there is a competition between, here both calcium channels and potassium channels play a role. Now at this point the L time calcium channels will close, so and still the potassium channels are open, so they will repolarize the cell to the basement membrane, that is the cardiac action potential. So this large plateau phase of the cardiac action potential is the special thing of cardiac tissue, because it prevents the heart from going into tetany. Okay, it prevents the heart from going into tetany, uh, because whenever the cell is in a depolarized state, if you give some other impulse, it will not act, because it is refractory. When the cell is under action potential, already it is in the action potential, already the cell has minus outwards and plus inwards, so this period is refractory period. So this long refractory period is the special characteristic of cardiac action potential. That's why the heart muscle never fatigues till death of the patient. Till the death of the individual, the heart muscle doesn't fatigue, and they will not go into tetany. That's the special characteristic of heart muscle. That's about the action potential and pacemaker potential. Learn some basics of ECG. So in ECG, how you will record? This is the baseline. There will be P wave. P wave is nothing but depolarization of atria, and after that there will be a Q wave. Q wave is because of septal depolarization, and then R wave, that is nothing but depolarization of ventricle, QRS. Okay, then there will be repolarization, that is a T wave, repolarization of ventricle. Then in some cases U wave also. So this is P wave, this is QRS complex, and this is T wave, and this is U wave. This is also important. This represents atrial contraction. This QRS up to from here to here, this is uh, ventricular depolarization, and this is ventricular repolarization. Okay, ventricular repolarization. Remember one thing. So we have learned now the normal electrical wiring system of the heart. So whenever the ventricles are activated by the normal wiring, SA node to AV node and bundle of His, then this like this left and bundle branch, whenever this type of whenever the current flows through this activity, through these wiring system, then the QRS complex will not be white, it will be less than normally. The QRS complex is less than 3 small squares, or less than 0.12 seconds, milliseconds, less than 3 small squares. Okay, so whenever the cardiac action potential flows through this normal wiring, the QRS complex will not be wired. Okay, white, it will be not, it will not be white. Okay, it will be normal. But when the action potential is not utilizing this conduction system, this normal conduction system, either because the action potential is generated in the ventricles, and ventricles, the connection between the ventricles is slow. So because the depolarization is spreading slowly, so when for example, when the in arrhythmia, where ventricular tachycardia, something like that, or supraventricular tachycardia due to aberrancy, so the impulses are taking from some other path, like from accessory pathway. So not from accessory pathway, for example from ventricles, so they will depolarize slowly, ventricle will depolarize slowly. So at that time what will happen, when this normal conduction system is not utilized, that time the QRS complex will become wide, bizarre like this, okay, or maybe like this. Just this is the concept you need to remember. Whenever the current flows to the normal wires, QRS complex will be uh, what do you call, narrow, and whenever the action potential is not utilizing this normal wire system, the QRS complex would be wide. This you should remember, okay. And one more point, whenever the normally P wave will be like this, but whenever that uh, the atrial conduction is disturbed, no, so either there will be no P wave, or there will be abnormal P wave like this, or like this, something like this. So that means that P wave is not generating from the SA node AV node pattern, it is from some ectopic foci that will be there, or some circuits, okay. So that's about the basics physiology of the action potential and all those, okay. Now we will move to the main topic. First, I will just zoom it. How do you define and classify cardiac arrhythmias? General considerations. A cardiac arrhythmia is an abnormality in the rate, regularity, or site of origin of the cardiac electrical impulse. They range from benign incidental findings to immediately life-threatening conditions. So any abnormality in the rate, regularity, nothing but rhythm, or site of origin. Rate, rhythm, or site of origin is nothing but cardiac arrhythmia. Okay. Now, this is the most simplified classification of cardiac arrhythmias based upon the rate, QRS complex width, and regularity on ECG. Very simple classification, very simple to remember, very simple to approach any case of arrhythmia. First, what you see whether there is tachycardia or bradycardia. What is the heart rate? Tachycardia is nothing but heart rate more than 100 beats per minute, and bradycardia is nothing but heart rate less than 60 beats per minute, okay. So whenever there is heart rate is more than 100, just you see next what is the thing you see, whether the QRS complex is wide, meaning more than 3 small squares, or narrow, meaning less than 3 small squares, okay. You see the width of the QRS complex. If it is narrow, then it is supraventricular tachycardia. What is SVT? SVT is nothing but any tachyarrhythmia, or any tachyarrhythmia which is originating above the bundle of His, including SC node, both atrium, okay, and AV node, atrioventricular node, okay. So any arrhythmia originating from these sites is known as supraventricular tachycardia. Below this site, may it be bundle of His, or ventricles, or other than this, downside of this, that is known as ventricular tachycardia or ventricular tachyarrhythmia, okay. So it is supraventricular tachycardia. If the QRS complex is narrow, it is supraventricular tachycardia, nothing. When it is narrow, that means the action potential is passed through the normal wiring system of the heart, and the impulses are generated either from SA node, or from AV node, or from some ectopic foci or circuit in these things. So it is SVT. Now you check the regularity. If it is irregular, most commonly it is atrial fibrillation. Just remember atrial fibrillation. If it is irregular, it is RR intervals you will see for regularity. If RR intervals are irregular, it is atrial fibrillation. If RR intervals are regular, then it can be either sinus tachycardia, Sinus tachycardia. Sinus tachycardia, what will be there? Normal things. There will be P wave, there will be QRS complex. Okay, in sinus tachycardia, P wave, QRS complex, T wave, again P wave, QRS complex, T wave, P wave, QRS complex, T wave. So every P wave is followed by a QRS complex. That is nothing but, that is, every P wave is followed by a QRS complex. That means the impulses are generated from the SA node. So that is sinus tachycardia. When this analogy is not followed, then it is not sinus tachycardia. It is not sinus tachycardia. Okay. Or it can be AVNRT. What is AVNRT? Atrioventricular nodal reentrant tachycardia. So there will be circuit in the AV node. There will be a circuit in the AV node itself with a fast pathway and slow pathway. Fast pathway and slow pathway. So that circuit is causing the tachycardia. That is nothing but AV nodal reentrant tachycardia. AV nodal reentrant tachycardia. Okay. So what you will see in ECG for this classical is P wave will be submerged in the QRS complex. P wave will be submerged. You will not see any P wave. It will be either you will not see the P wave, or you will see the P wave in the form of some R dash wave. I will one more time. In AVNRT, first one, either you will not see any P wave, or you will see the P wave in the form of R dash wave. Okay. Or you will see the P wave just after the QRS complex. So here the P wave is submerged in the QRS complex. It is now, here it is in the form of like R dash, and here it will be just forward to the QRS complex. So this is AV nodal reentrant tachycardia. Next is atrioventricular, AVRT, atrioventricular reentrant tachycardia. So in AVRT, remember always, AVRT, there is always a accessory pathway. And this accessory pathway, this is the AV node. This is the accessory pathway. So through this accessory pathway, the conduction can be like this. If this is like this, the conduction, if it is like this, then this is known as orthodromic conduction. But if the conduction is opposite side like this from this accessory pathway, then it is known as antidromic conduction. In this case, if it is opposite, then it will generate a circuit there, and there will be a tachyarrhythmia, supraventricular tachycardia. Okay, antidromic condition. So these two types of conduction are there in AVRT when there is accessory pathway. Sometimes this pathway will not act; it will be silent. Okay, and only this normal wiring will be utilized. Okay, so that is known as concealed pattern, concealed WPW syndrome. Okay, this is nothing but WPW syndrome, presence of accessory pathway, concealed pattern. Okay, and when it is like this, some orthodromic conduction or antidromic conduction, that is known as manifest form of WPW AVRT, manifest form of AVRT and concealed form of AVRT. Okay, remember that thing. And AVRT, what you will see, when the impulses is normally conducting from both from the accessory pathway and from the AV node. So this accessory pathway will be fast. It will conduct fast to the ventricles. So that's why, because it is conducting fast to the ventricles, then this normal wiring. So P wave will immediately followed by a QRS complex, and that QRS complex will have slight slurring like this, slurring, then like this. Okay, like this, slurring like this, then T wave. Okay, so here the PR interval is reduced. Why it is happening? Because the impulses are conducting fast through the accessory pathway. PR interval is reduced, and you will have this is known as delta wave. This slurring is known as delta wave. This is when there is orthodromic conduction. Okay, so that's how you recognize the AVRT. Now atrial flutter. What is atrial flutter? So there will be a large circuit in the atrium, which will bombard the AV node, with impulses, which will bombard the AV node with many impulses. For example, it will be like 200 to 300 times impulses per minute. 200 to 300 impulses per minute it will generate this circuit, this atrial flutter. Okay, but because the AV node has very high resistance, so it will not conduct every impulses it receives. Okay, commonly it will conduct in the form of 2:1 pattern, meaning for every 2 impulse it will conduct 1, or it will conduct in the form of 3:1 pattern. Okay, 2:1 pattern or 3:1 pattern. So this is also supraventricular tachycardia, but you will not know. Okay, you will have P wave, again P wave, now QRS complex, P wave, QRS complex. So every second P wave will have QRS complex. Okay, but you will not understand. You will think this is as T wave, and again this as P wave. This is very much confusing. So when you will give adenosine, so what adenosine will do? Adenosine will increase the resistance of AV node. So all of the much higher number of impulses are broken down to conduct downside. So what will happen? At that time you will have like this type of pattern. This is nothing but sawtooth pattern of appearance. This is nothing but atrial flutter. So at some point one QRS complex will be there, because you are increasing the resistance of AV node by giving adenosine. Okay, this is atrial flutter. Okay, atrial tachycardia. What's happening in the atrial tachycardia? So as the name suggests, some ectopic foci will take over the paceover function, and it will generate more impulses. So from the atrium it is coming. So some other foci other than SO node, so it is coming. So you will have some abnormal P wave, see like this. So this is monomorphic. Okay, this is known as monomorphic atrial tachycardia, when there is only one ectopic foci which is producing tachyarrhythmia. Monomorphic atrial tachycardia. But sometimes what will happen in atrium, there are multiple foci, say some 4. They will send impulses to the AV node. Okay, so one time you will have like this, P wave, sometime you will have like this P wave, sometime you will have like this bifid wave. So every P wave will have different morphology. So that is nothing but polymorphic. Why every P wave is different? Because foci are different. this foci will have some PVA morphology, this foci will have some PVA morphology, this foci will have some PVA morphology. So that's why it is known as polymorphic atrial tachycardia, which is very much common in COPD patients. Polymorphic atrial tachycardia. Polymorphic atrial tachycardia, PAT. Okay, that's about regular. So that is the challenge which one faces when there is SVT and regular RR interval. So we have to differentiate between, it is easy to differentiate between sinus and non-sinus, but in non-sinus, AVNRT, AVRT and atrial tachycardia. Remember these three: AVNRT, AVRT and atrial tachycardia, these three. And one more you can take as atrial flutter. This non-sinus tachycardia we need to differentiate, okay, in ECG. And I have explained the characteristics just now, how they will present in ECG. Sinus tachycardia will follow P wave, QRS complex, T wave, P wave, QRS complex, T wave, P wave, QRS complex. So the P wave will be there, normal P wave, normal QRS complex. So that is sinus tachycardia. That's how you differentiate that. If that analogy is disturbed, then it is not sinus tachycardia. If it is irregular, common cause is atrial fibrillation. What is atrial fibrillation? Atrial fibrillation is nothing but electrical chaos. Electrical chaos in atria. Electrical chaos in atria, meaning the atria are not contracting, they are just shivering. Many thousands of microcircuits will send impulses to the AV node. Thousands of microcircuits will send impulses to the AV node. So, and they will be in coordination between them. So sometimes this will send, sometimes this will send, and sometimes, so as a AV node will be bombarded with many of the impulses. So there will be irregular pattern. Okay, some will be close, some will be like this. Because of this, many minute circuits which are generating the impulses in atrial fibrillation. Because of that, the atrial will not fibrillation. No, atrials are just fibrillating. They're just shivering. So they are not able to pump blood to the ventricles. So ventricles will receive less blood and they'll be having reduced cardiac output. Okay. Now this atrial fibrillation can be paroxysmal. Atrial fibrillation. I'm just giving this overview of tachyarrhythmia. Atrial fibrillation can be paroxysmal, meaning episodic paroxysmal atrial fibrillation, or it can be persistent atrial fibrillation, or it can be prolonged atrial fibrillation. This is up to 7 days. Paroxysmal. Persistent is 7 days to 1 year. Some books say one year, some books say 2 year. Okay, and prolonged is more than 1 year. These are three types of atrial permanent: paroxysmal, persistent, permanent. I think prolonged is nothing but permanent atrial fibrillation. Okay. Now, when it is wide complex, one golden point you remember: whenever there is wide complex tachycardia, just think it as ventricular tachycardia unless proved otherwise. You think it as ventricular tachycardia and treat it as ventricular tachycardia. Okay, that is very important. So now we will break down this. If it is regular, either it is ventricular tachycardia or it is supraventricular tachycardia due to SVT with aberrancy. What is SVT with aberrancy? SVT with aberrancy is nothing but it is supraventricular tachycardia only, but that supraventricular tachycardia, instead of producing a narrow complex, now it is producing wide complex, which should not happen. But why it is producing narrow complex? Because of aberrancy. What that aberrancy is? Either a right bundle branch block or a left bundle branch block, or a accessory pathway. So because of these things, an SVT is presenting like a wide complex tachycardia. That is nothing but SVT with aberrancy. That is the challenge we face when we have a wide complex tachycardia. We need to differentiate between whether it is ventricular tachycardia or it is SVT with aberrancy. But if the treating doctor is a fresher, if he is in confusion, treat it as a ventricular tachycardia, because if you treat with beta blockers or something, it will break down into ventricular fibrillation. Otherwise, sudden cardiac death can happen. Okay, so SVT is presenting with wide complex tachycardia because of right bundle branch. What will happen when there is wide bundle branch? This is the AV node. This is the bundle of his. Okay, and this is the right bundle branch and left bundle branch. So when there is blockage here, so this impulse should go to the left ventricle, and from there it should come to the right ventricle, because there is delayed depolarization of the ventricles because of blockage either here or here in the left bundle. That's why the complex is becoming wide. Okay, the complex is becoming wide, but due to SVT. But that should not happen. That is happening because of this RBB, left BB, or some accessory pathway. So because accessory pathway, if it is there and some SVT is there and that impulses are conducting from here, so because the impulses are not following the normal wiring, they are following an abnormal wiring, the QRS complex will become wide. Okay, so SVT with aberrancy will respond to beta blockers or centrally verapamil or diltiazem. Okay, but VT will not respond. VT will break down if you use in ventricular tachycardia. If you use beta blockers, no, they will not respond. There is a dangerous thing which is going to happen. Okay, that's why always wide complex tachycardia, think it as VT unless proved otherwise. When it is regular, okay. Well, if it is irregular wide complex tachycardia like this, I will show. Okay, so this is nothing but polymorphic ventricular tachycardia or ventricular fibrillation. Polymorphic ventricular tachycardia, also known as Torsades de Pointis. Torsades de Pointis. So wide complex tachycardia with irregular rhythm is nothing but Torsades de Pointis. Polymorphic ventricular tachycardia. What is polymorphic ventricular tachycardia? Each some QRS complex will be positive, some QRS complex will be negative. So QRS complexes will be of different morphologies. That's why it is known as polymorphic ventricular tachycardia. Okay, or it can be ventricular fibrillation. In ventricular, just you will see like this type of waves. Okay, fibrillation. That's about the chart overview of basic classification, and this is the easiest and overview easiest classification which one can follow to identify the arrhythmia and treat the arrhythmia. Just I will for knowledge purpose, wide complex tachycardia treat with amiodarone. Narrow complex tachycardia treat with first you carotid sinus massage. You give, not resolving, give adenosine. Now this adenosine 6 mg will give. This will act as it is useful as a therapeutic drug also, and it can be used for diagnostic purpose also. How? It will block the AV node, and you can differentiate between different types of, for example, as we have seen atrial flutter. So 2:1 conduction, 3:1 conduction. When you block, you see a fluttering waves there. So that's how you that's how you identified that it was atrial flutter, no, by giving adenosine. When it is not responding to adenosine, you can give beta blockers. So mainly what you are doing, you are blocking the AV node. You are blocking the AV node. So because the circuits mainly they go through the AV node, or if the circuit is not through the AV node, the impulses which are coming from the atria, they also go through the AV node. So you are blocking the AV node so that the ventricles fill properly. When the ventricles fill properly, they will give a good cardiac output and blood pressure is maintained. That is the main goal. Okay. Just to revise, whenever there is tachycardia more than 100 beats per minute, just see the QRS complex. If it is narrow, then it is SVT. If it is irregular, then it is atrial fibrillation. If it is regular, it can be sinus and non-sinus. In non-sinus, it can be AVNRT, AVRT, and atrial tachycardia. If it is wide complex, think it as ventricular tachycardia unless proved otherwise, or it can be SVT due to SVT with aberrancy. If it is regular, it can be AVT or SVT with aberrancy. If it is irregular, it is polymorphic ventricular tachycardia or ventricular fibrillation. So I think this is enough for today. uh, many things are there to learn in arrhythmias. Arrhythmias are not easy topic. They are complicated topics. We will learn step by step. Thank you for your listening.